Imagine going into surgery to, cure a really debilitating chronic pain, only to discover that the very procedure designed to heal you practically guarantees the pain is going to return.
Yeah, it is honestly the ultimate surgical catch-22.
Right. And for so many people, it is happening right inside their abdomen. You reached out to us with this highly specific, deeply lived question. You asked, can severe pelvic tissue adhesions from a prior ruptured appendix create fixed tethering that causes deep positional pain today?
And it is such a profound question, really, because it forces us to look at how the body's self-defense mechanisms, the very cascades that keep us alive during a massive infection, can actually become the architectural blueprint for long-term chronic illness.
Absolutely. So for this deep dive, our mission is to trace that exact biological journey, connecting the dots from your initial abdominal trauma all the way to the specific mechanics of your current pelvic pain.
Right, and we have a massive stack of sources today to help us do that.
We do. We're pulling from Surgical Society reviews on peritoneal healing, NHS diagnostic guidelines, some really advanced gynecological clinical studies, and evidence-based physical therapy protocols. So, okay, let's unpack this.
Let's hear it.
When the appendix ruptures, we know it breaches the peritoneal cavity. But mechanically speaking, what is the body actually doing in those first few hours to try and stop what is basically a lethal infection?
Right, so it initiates this massive biochemical lockdown.
Mhm.
I mean, the peritoneal cavity, which is the space housing your abdominal and pelvic organs, is usually a highly controlled, totally sterile environment.
Right, completely clean.
Exactly. So when an appendix bursts and just floods that space with bacteria and necrotic tissue, it triggers acute peritonitis. The immune system detects this catastrophic breach, and within just 3 hours, these specialized cells called macrophages flood the entire area.
Wow, 3 hours is fast.
It is incredibly fast.
Yeah.
And they release a storm of cytokines, which are, essentially chemical distress signals.
And those signals basically tell the body to build a wall around the infection.
Yeah, but it's less of a wall and more of an aggressive sticky sealant. The body begins pouring out this fibrinous exudate. Following the chemical trail left by those macrophages, cells called fibroblasts arrive and rapidly construct a fibrin gel matrix right over the damaged tissues.
So it's kind of like an internal scab.
Yes, exactly. It's a biological spackle designed to instantly seal off the leak and trap the bacteria before they can go systemic and kill you.
Okay, that makes perfect sense for an emergency trauma response. But I mean, any scab on your skin eventually dries up and falls off once the underlying tissue is actually repaired, right?
Right, normally.
So if this internal spackle is supposed to be a temporary patch, why is it still wreaking havoc inside a patient's pelvis years later? I mean, it sounds like the body is panicking and using way too much super glue to fix a leak, and when it dries, it accidentally glues a bunch of neighboring pipes together. Why doesn't that internal glue just dissolve over time?
Well, normally it does. In a perfectly healthy healing cascade, once the tissue is repaired, usually within about 5 to 7 days, the body releases an enzyme called plasmin.
Okay.
And this enzyme drives a process known as fibrinolysis, which literally dissolves that temporary fibrin matrix. It basically cleans up the scaffolding. But, and here is the key, a severe event, like a massive rupture or a really severe infection, completely derails that cleanup crew.
Wait, how does an infection stop an enzyme from doing its job?
It comes down to oxygen and inflammation. Severe inflammation actually compresses local blood vessels, leading to a lack of oxygen in the tissue. We call this hypoxia.
Oh, I see.
Yeah, and hypoxia actually suppresses the chemical precursors needed to make that cleanup enzyme. So the fibrinolysis just fails, the temporary fibrin matrix doesn't dissolve,
Yeah.
and because it just sits there, the body eventually assumes, oh, this is supposed to be a permanent structure.
Oh, wow.
Right. So blood vessels begin to grow into the gel, a process called angiogenesis, and they bring these collagen-producing cells right along with them.
So the body essentially paves over the temporary spackle with permanent concrete.
That is a brilliant way to put it, actually. What started as just a sticky gel matures into dense, vascularized bands of fibrous connective tissue. We call these adhesions.
And what do they look like?
Well, they can look like thin, translucent sheets of plastic wrap, or they can develop into thick, highly vascularized bands that literally hold adjacent structures together in a vice grip.
Which directly sets up the core of your question, basically how this past event causes deep positional pain today. Because, I mean, these organs aren't meant to be bolted together like that. Normally, organs glide, right?
They absolutely do. In a healthy abdomen, organs like your bowel, your bladder, uterus, ovaries, they're coated in this specialized lining called the peritoneum.
Right.
And that lining contains mesothelial cells, which produce a really slick, lubricating fluid. So when you bend over or, when you digest a heavy meal or twist to reach for something, your internal organs are supposed to effortlessly slide past one another in a totally friction-free environment.
But these new collagen bands, these adhesions, they must completely ruin that sliding
So
mechanism.
completely. They create what is clinically termed fixed tethering. They physically anchor organs to one another, or to the dense muscular wall of the abdomen, or even down to the pelvic sidewall.
That sounds incredibly restrictive.
It is. Your bowel might become totally fused to an ovary, or your bladder might be tethered directly to your pelvic floor.
But wait, if this internal glue is just connective tissue, basically just dead collagen, why is it causing such severe pain? I mean, a piece of string doesn't hurt when you pull it. Is the pain just coming from the organ itself being stretched out of place?
For decades, that was the prevailing medical assumption. Surgeons genuinely believed that adhesions were inert, dead scar tissue.
Oh, really?
Yeah, they thought the pain was solely a byproduct of the healthy organs being mechanically distorted. But a really landmark study by Suleiman and colleagues fundamentally shifted our entire understanding of this. They analyzed adhesions that were extracted from women undergoing surgery for chronic pelvic pain.
And what did they actually find inside that tissue?
What's fascinating here is that they didn't just find collagen. They ran very specific histological stains on these adhesions and discovered that almost all of them contain active sensory nerve fibers.
Wait, are you saying the pain isn't just coming from the organs being pulled out of place, but that the scar tissue itself can actually feel pain?
Yes, exactly. Specifically, they found nerves expressing substance P and calcitonin gene-related peptide.
Which are what, exactly?
They are neurotransmitters that are directly involved in transmitting pain signals.
Hang on, I just want to make sure I am grasping the magnitude of this. The scar tissue itself isn't dead filler. It actively grows its own pain receptors.
It does. When those new blood vessels grew into the original fibrin gel to, solidify it, nerve fibers followed right alongside them.
Oh.
The evidence shows that these adhesions are neurologically active, completely regardless of how old the adhesion is, or even how small it might appear.
Oh my God, here's where it gets really interesting, because that entirely reframes the patient experience. When you move, you aren't just tugging on a dead piece of internal rope, you are basically stretching a live wire.
Yes. And that right there is the exact mechanism behind the deep positional pain you asked about. The pain is fundamentally tied to mechanical tension. Because the adhesion contains its own nerve endings, any shift in posture, any deep stretch, or honestly even normal bodily functions stretches that tether.
Like just digesting food.
Exactly. An intestine expanding with gas, or a bladder filling up with fluid. That mechanical stretch fires those localized nerves, resulting in the sharp stabbing or pulling pain that seemingly comes out of nowhere just when you change positions.
Okay, so if this is a physical mechanical reality, if we're talking about live wires and dense bands of collagen physically trapping organs, why on earth do so many patients get told their scans are completely normal?
It's incredibly frustrating.
Right, like if an adhesion is thick and dense enough to completely trap an ovary or block a bowel, how on earth is an MRI missing it? They can see a tiny millimeter tear in a knee meniscus, but they miss a fibrous band choking a bowel. I can only imagine how maddening it is for you, sitting in a doctor's office in absolute agony, only to be handed a quote-unquote clean scan.
The psychological toll of that specific scenario is massive. Patients frequently get told it might be psychological, or they get misdiagnosed with irritable bowel syndrome. But the clinical reality is that standard medical imaging is essentially blind to adhesive disease.
Completely blind.
Pretty much.
Wow.
Blood tests, x-rays, standard ultrasound, CT scans, and MRIs generally cannot see them at all.
Why not, though? The technology is incredibly advanced. What is the actual physics behind the blind spot?
It's all about tissue density and contrast. A CT scan differentiates structures based on how much they attenuate or block x-rays. And the MRI differentiates based on water content and magnetic properties.
Right.
But adhesions are made of the exact same basic connective tissue components as the outer layers of the organs they are binding together.
So they just sort of blend right into the background.
Exactly. Unless an adhesion is actively causing a severe secondary complication, like a total bowel obstruction where the intestine is visibly ballooned out with fluid and gas upstream of the blockage, the band of scar tissue itself perfectly matches the density of the surrounding tissue.
Wow.
It basically just looks like one continuous mass of gray on the monitor.
Is there literally no imaging that can catch this?
There is one dynamic technique. It's called the visceral slide test. Using a specialized ultrasound, a technician will ask the patient to take really deep breaths while they watch the abdominal wall.
Okay, what are they looking for?
Well, instead of looking for the adhesion itself, they look for the absence of movement. They're looking to see if the normal shear planes, where tissue should glide freely, are just stuck. It can sometimes hint at tethering, particularly around the belly button, but generally speaking, imaging fails these patients.
Man, so we have a patient with invisible nerve-dense tethers pulling on their organs. They are in chronic daily pain, but the diagnostics say they are perfectly healthy. Biologically, what does that relentless, totally unvalidated pain actually do to a person's nervous system over time?
It often triggers a really devastating secondary condition known as central sensitization.
I've actually heard that term in relation to fibromyalgia. How does it work here?
Well, when your peripheral nervous system is subjected to chronic, unremitting pain signals, especially pain that unpredictably spikes with basic everyday movements, it just bombs the spinal cord and brain with distress signals.
Oh, I see.
Over time, the central nervous system adapts by essentially turning the volume dial on pain all the way up, and it gets stuck there. Your nervous system becomes incredibly hyperreactive.
Meaning it takes less and less tension to cause more and more pain.
Precisely. A tiny pull on that adhesion might suddenly register as a massive, agonizing tear.
Mm.
Furthermore, your body naturally tries to protect you from pain through muscle guarding.
Like clenching.
Yes. The muscles of the pelvic floor unconsciously clench to splint the area and try to stop the organs from moving. Months or even years of this constant clenching causes those pelvic floor muscles to become shortened, tight, and highly painful themselves. It basically creates a compounding loop of mechanical and neurological dysfunction.
So if the scans are useless and the nervous system's just constantly escalating the pain, how does the surgeon actually confirm it's pelvic adhesive disease and, how do they fix it?
Well, the only definitive gold standard way to diagnose adhesions is direct visualization via laparoscopy.
Which means surgery.
Yes, the surgeon inflates the abdomen with gas, inserts a camera through a small incision, physically sees the bands of scar tissue, and cuts them. And the cutting of adhesions is a procedure called adhesiolysis.
Which brings us right back to the paradox we started with, because cutting the tissue causes trauma, which is exactly what triggers that whole fibrin spackle response in the first place, right?
It is the ultimate surgical catch-22. To cure the disease, you literally have to inflict the very injury that causes it.
That is just wild.
And the numbers back that up. Up to 93% of patients who undergo abdominal or pelvic surgery develop new adhesions. I mean, the peritoneum is incredibly sensitive. Even just the exposure to the dry, cool air of an operating room instantly desiccates and damages those fragile mesothelial cells.
Wow, just the air.
Just the air, let alone the trauma of scalpels or cauterizing tools. If we connect this to the bigger picture, surgery is the gold standard for diagnosis and treatment, but it's also the primary cause of the disease.
So what does this all mean for the patient? The cure is also the cause. Are they just doomed to an endless cycle of surgeries?
It means it requires extreme surgical caution. Clinical data actually shows that for patients with mild filmy adhesions, undergoing adhesiolysis might not offer any more long-term pain relief than a placebo.
Really? A placebo?
Yeah. The immediate pain might stop because the tether is cut, but as the new surgical wounds heal, new adhesions form, and the positional pain often returns within months.
So under what circumstances is the surgical risk actually worth taking?
It is absolutely necessary in life-threatening scenarios, like a bowel obstruction. It is also highly beneficial for dense, highly vascular adhesions that are severely distorting the anatomy.
Can you give an example?
Sure, a prime example is trapped ovary syndrome, where an ovary becomes completely encased in dense scar tissue. The ovary continues to cycle and form follicles, but the swelling is trapped by the rigid scar tissue, which causes excruciating pain. In those specific severe mechanical cases, surgery really is often the only path to relief.
But if they have to operate, surgical technology must have evolved to break this cycle somehow. How do they stop the new spackle from instantly fusing the organs back together while the patient heals?
Surgeons now employ an array of preventative techniques. First, minimizing trauma is absolutely key. They use hydrodissection, which basically uses a highly pressurized microscopic stream of fluid to gently separate tissue layers before cutting, rather than using blunt force.
Oh, that sounds vastly gentler on the tissues.
It is. But the most significant game changer has been the development of bioresorbable barrier membranes.
How do those work? I'm sort of imagining wrapping the organs in something to keep them apart.
That is essentially it, actually, but at a biochemical level.
Mm.
Products like Ceprafilm or Interseed are synthetic shields. You can think of them a bit like biodegradable agricultural ground cover.
Okay.
A farmer places ground cover over the soil to prevent weeds, or in our case adhesions, from taking root, which allows the main crop, the healthy organs, to establish themselves.
But how does a synthetic sheet dissolve inside the body without triggering a massive foreign body immune response? Wouldn't the body just attack it and make even more scar tissue?
That is the absolute brilliance of their design. Many of these barriers are made of chemically modified hyaluronic acid, which is a substance that naturally occurs in the human body.
Go clever.
Right. So when the surgeon places this film between, say, a freshly freed ovary and the bowel, the film quickly turns into a viscous hydrophilic gel. It physically separates the raw tissues during that critical 5 to 7 day window when the fibrin matrix is desperately trying to fuse things together.
So it physically blocks the fibrin from bridging the gap.
Exactly. And because it's based on natural sugars, once the raw tissues have healed over with a new, slick mesothelial layer, the body naturally metabolizes the gel. Macrophages break it down through hydrolysis into water and carbon dioxide, and it just safely clears the system.
That's amazing.
It doesn't drop the recurrence rate to zero, but it drastically reduces the severity of the adhesions that do end up forming.
Okay, let's pivot to the patient who has this deep positional pain. They know they had a ruptured appendix, but they are not in a state of bowel obstruction. They want to avoid the surgical catch-22 entirely. What are the conservative options to actually manage this?
This is where we rely heavily on a multidisciplinary approach, focusing heavily on targeted physical therapy, specifically specialized pelvic floor therapy and visceral mobilization.
Visceral mobilization. If I go to a PT, do they just push deep into the abdomen and try to manually snap the scar tissue bands?
No, absolutely not. Attempting to forcefully snap or tear an adhesion would cause microtrauma, bleeding, and trigger the exact inflammatory cascade that builds more adhesions. It would be an absolute disaster.
So what are they actually doing when they mobilize the organs?
They are utilizing a principle called mechanotransduction. A highly trained physical therapist uses sustained, really gentle manual pressure to stretch the tissues over time. They aren't trying to break the string. They're trying to change the elasticity of the surrounding fascia and tissues.
Oh, I see.
Yeah, if you can create even a few millimeters of additional slack in the fascial system, you drastically reduce the mechanical tension on those trapped nerves.
So it's like if surgery is like trying to untie a knot with a pair of scissors, risking cutting the rope entirely, physical therapy is like slowly massaging the knot until it loosens up enough to give you some slack. You just want to give the live wire some slack so it stops firing every time you stand up.
Precisely. That is a great analogy. And equally important, they address that central sensitization loop we discussed earlier. They work on the pelvic floor muscles to downregulate the nervous system. They teach the patient how to identify muscle guarding and actively release those chronic contractions.
And what about medication?
Alongside the physical therapy, physicians may prescribe nerve-targeted medications like gabapentinoids. These specifically calm the hyperexcitability of those sensory nerves that are trapped in the scar tissue. It's about managing the neurology and the mechanics simultaneously.
So to bring this all the way back to the incredibly insightful question you said.
That is.
A ruptured appendix from years ago absolutely can trigger a rogue healing cascade that paves over a temporary fibrin patch with dense permanent collagen.
Yes.
And those tethers grow their own sensory nerves, becoming literal live wires that transmit deep, sharp pain every time mechanical tension is applied.
It is so vital to validate your experience here. The invisibility of this disease on MRIs and CT scans leaves way too many patients feeling entirely gaslit by the medical system.
Yeah, you aren't crazy.
Exactly. The structural, neurological, and physiological reality of adhesive disease is completely documented and undeniable. Your pain is real, it has a physical origin, and it is a complex legacy of your body trying to save your life during that initial rupture.
It really is a double-edged sword. The immune system acted with such ferocity to keep you alive. It fundamentally altered your internal architecture.
Which leads to perhaps the most fascinating, lingering mystery in peritoneal science today. Throughout the clinical literature, researchers frequently point to idiopathic factors governing adhesion formation.
Idiopathic meaning they just don't know why it happens.
They don't know why the severity is so incredibly unequal between individuals. I mean, you can have two patients undergo the exact same major open abdominal surgery. One patient heals perfectly clear, their organs gliding smoothly as if absolutely nothing happened.
And the other?
The other patient, perhaps from just a tiny microscopic scrape during a routine procedure, develops massive, dense internal superglue that fuses their entire pelvis into a solid block.
That is wild. It's as if their bodies are operating on completely different operating systems for healing.
It raises a really important question at the frontier of surgical science, which is, does our DNA contain a specific scarring profile?
A scarring profile.
Yeah. Are some of us genetically predisposed to overproduce fibrin, fail at fibrinolysis, and grow nerve-dense adhesions in response to even the slightest trauma, while others are basically immune to internal scarring?
Man, if we could decode that, we could predict exactly who is at risk before they ever go under the knife.
Exactly. Understanding that genetic predisposition could completely revolutionize how we approach surgery, preventative barriers, and honestly, the management of chronic pain in general is a really profound concept to ponder as you navigate your own understanding of how your body uniquely healed and adapted to survive.
It is an incredible thought to leave on. Thank you so much for sending in such a brilliant, deeply specific prompt that allowed us to explore this today. Until next time, keep digging deeper.